Welcome to the Deep Dive, the place where we take complex, often dense professional source material, the stuff that forms the foundation of your career, and distill it down to the most important, memorable, and actionable insights.
Today, we are undertaking a deep dive into the regulatory backbone of nursing. This might sound like a dry topic. We're talking licensure, certification, and all those acronyms for professional organizations.
Right.
But these structures are truly the bedrock of modern healthcare. They're the mechanisms that determine who gets to practice, what they get to do, and crucially, how the profession maintains control over its own destiny.
I think that's the key insight we have to establish right up front. We're not just looking at bureaucratic hoops to jump through.
No, not at all.
We're looking at how nursing regulates itself, and not just for the profession's sake, but, and this is the critical part, to protect the public.
Exactly.
In a world that's been shaped by the Affordable Care Act, accelerating technology, and just, shifting consumer demands, the professional role of the nurse is expanding and becoming exponentially more complex.
It is. And these regulations are the only way to manage that complexity safely. Historically, you can see the evolution of nursing standards mirrors the explosion of medical science.
How so?
Well, when early care was, primitive, regulation was minimal. It was almost non-existent. Anyone could basically hang a shingle and claim to be a nurse.
Wow.
But as technology advanced and as public expectation for successful outcomes grew, robust standards, things like licensure and certification, they became non-negotiable safeguards. The stakes are just too high now.
So if you are a prospective nurse or, even a seasoned one, why should you be paying attention to the intricate details of these organizations?
Because they are the difference between having regulations dictated to you by others.
Like hospital administrators who are obsessed with the bottom line.
Right? Or medical societies who, frankly, still see nurses as subordinates and having the political power to shape those regulations yourself. If you want professional independence, if you want the freedom to provide effective care, that power comes directly from these organizations and their ability to lobby and establish standards.
Okay. So our mission today is to give you a comprehensive roadmap. We're going to teach you the essential framework step by step.
We will. We'll cover the foundation, like the difference between, say, historical permissive licensure and today's mandatory standards, and why the Nurse Practice Act is the legal authority you absolutely have to understand.
And then we'll move into the more advanced professional standards.
Yes, the meaning of certification. And finally, the great unifying force behind advanced practice, the APRN consensus model, which is executed through its blueprint, LACE.
Okay, let's unpack this framework. We begin where all professional power starts, defining who is qualified. We are jumping into Section 1, exploring the absolute foundation, Licensure and Nurse Practice Acts.
Perfect place to start.
To understand the power of a license, we really have to look back at the chaos that came before it. Picture the mid-19th or early 20th century. Hospitals were growing incredibly fast, but there was no official system of, competency control. Our sources paint this provocative scenario. Literally anyone could walk into a hospital, claim to know how to care for clients, and be given a job as a nurse. There was just no vetting.
It's astonishing by modern standards, but that was the reality.
Yeah.
And the result was massive variations in ability, which led to inconsistent and, frankly, often unsafe care.
So nursing leaders at the time, they saw this firsthand.
They did, and they recognized that the only way to protect the public and build the profession's credibility was through what we call credentialing, a way to ensure a baseline competency.
And this wasn't an easy sell, was it? I mean, the push for official registration and standardization faced some incredible resistance.
Oh, huge resistance?
Who was fighting against the very idea of professional standards.
Well, the opposition came from three main champs. First, you had many hospital administrators who preferred the cheap labor of uncertified caregivers.
Of course.
Second, some physicians viewed standardized nursing as a threat to their control over the healthcare team. And maybe most surprisingly, some practicing nurses, especially those who had just learned on the job, they feared that mandatory registration would invalidate their experience and restrict their ability to practice freely.
So, despite all that resistance, the movement did gain traction. Where did that initial push for formal registers come from?
It really started with figures like Florence Nightingale. She recognized the value of competence and established the first formal list, or register, for the graduates of her own nursing school.
Okay.
In the United States, organizations like the Nurses Associated Alumnae, that was the precursor to the ANA, they tried in 1896 but failed legislatively.
Yeah.
It took just relentless effort from nursing pioneers like Lillian Wald and Annie Goodrich, who understood that inconsistent quality was a direct threat to public safety.
This effort finally reached a critical international head in 1901.
Yes. The International Council of Nurses passed a resolution that year demanding that every national member establish a system for state licensure and examination procedures. This really set the global standard and put a lot of pressure on individual states.
And this brings us to a foundational legal milestone, the state of New York in 1904. Why is the passage of New York's licensure bill so historically significant?
Because it moved beyond just, registering graduates.
Yeah.
It established the standard for professional regulation that other states would eventually have to follow.
So what did it do specifically?
Crucially, the bill established minimum educational standards, requiring a basic nursing program of at least 2 years. It mandated that all nursing schools be registered with the State Board of Regents. But here's the real political punch.
What's that?
It established the State Board of Nursing, SBN, and it made sure that board was controlled by 5 nurse members.
Mm-hmm.
And it gave that board the power to formulate rules for examination and for license revocation.
I mean, think about the timeline here. Our sources highlight that this massive act of self-governance happened before women even had the right to vote in general elections.
Incredible.
This was nursing establishing political control over its own practice when the majority of its members had almost no political voice anywhere else in society. That's just a staggering achievement.
It truly redefined the profession. And once New York created that precedent, other states, even with weaker initial bills, were sort of compelled to follow. This historical necessity, this need for a standard, is what underpins the purpose of the modern licensure examination, the NCLEX-RN.
The NCLEX, the single exam that causes more anxiety than almost anything else for a nursing student. But if you strip away the anxiety, its purpose is singular, right? It's an objective, high-stakes method to prove that an individual is qualified to practice nursing safely.
That's it. It is a direct defense against the chaos of the unqualified practitioner of the past. And the standardization of this exam is its own story of continuous professional organization. Well, while all states had some form of exam by 1923, they varied wildly in content and format. So the ANA Council of State Boards of Nursing was organized in 1945 specifically to oversee the development of a uniform test that all state boards could adopt.
That uniform test was implemented in 1950, and after decades of refinement, it became the NCLEX-RN we know today, moving to a computerized adaptive testing, or CSE format, in 1994.
The technology changed, but the mission remains exactly the same.
Right.
Proving minimal competency for safe practice.
Yeah.
And that push for efficiency and mobility continues.
Right.
We're now seeing the push for the mutual recognition model, which aims toward a universal nursing license.
This allows nurses licensed in one state, a compact state, to practice in other regional agreement states without needing to be relicensed.
Exactly. And that ability to move without penalty is absolutely essential for a mobile, modern healthcare workforce, especially in fields like, travel nursing or telehealth.
So the NCLEX gets you the license, but the power structure that controls that license at the state level is the Nurse Practice Act, or NPA. Let's talk about that legal backbone.
Okay. The NPA is the definitive state legislation that regulates nurse practice. You can remember its primary functions as a sort of triad. First, to protect the public.
Okay.
Second, to legally define the scope of practice for nurses within that state. And third, to make nurses legally accountable for their actions.
And the MPA is the mechanism that creates and empowers the state boards of nursing, SBNs. What are the common regulatory powers granted to these SBNs by the state legislature?
They hold immense power. Their regulatory responsibilities include granting licenses, approving nursing programs within the state, establishing the essential standards for those nursing schools, and writing specific, detailed regulations that govern the practice of nursing generally within that jurisdiction.
And those rules written by the SBNs, they carry the force of law, right?
They carry the force of statutory law.
Yes. Let's focus on the disciplinary side for a second. The SBNs have the power to deny or revoke licenses, which is the ultimate enforcement mechanism for protecting the public.
It is.
What are the specific reasons listed that would trigger a license revocation?
This is the firewall. A license can be denied or revoked for serious offenses that directly threaten public safety. These include things like conviction for a serious crime, a demonstration of gross negligence or unethical conduct in practice, practicing nursing without maintaining your license renewal, drug or alcohol use that impairs judgment and affects client care, or A willful violation of the state's specific Nurse Practice Act.
These measures ensure that the professional standard is not just established but actively maintained.
Exactly. And that unsafe practitioners are swiftly removed.
So beyond enforcement, what are the other essential functions of the NPA in defining the profession itself?
They are definitional. The NPAs provide the legal definition of nursing for that state and define the legal scope of practice for all licensed personnel. They explicitly rule on who can legally use the professional titles of registered nurse, RN, and licensed practical nurse or licensed vocational nurse, LPN, LVN.
And they govern all the bureaucracy, too.
All of it. They set up the application procedures and fees for licensure and renewal, and crucially, they determine the regulatory guidelines for expanded practice roles, like the Advanced Practice Registered Nurses or APRNs.
It's clear that the NPA is the absolute legal foundation. Now let's move into Section 2, where we can clarify some of the historical and current challenges surrounding these legal definitions. We need to clarify the difference between registration and licensure.
It's a common point of confusion, even for professionals, because the terms get used interchangeably in casual conversation. But technically, they're very distinct.
Let's start with registration. What does that term specifically mean in a regulatory context?
Registration is really the simplest form. It's just the listing of names on an official roster after certain pre-established criteria have been met.
Okay, so it's a list.
It's a list. The term registered nurse implies its historical origin came from institutions needing to verify that an applicant's name was on the register or official roster of nursing school graduates.
And licensure elevates that concept.
Yes, licensure is conducted by the state using its delegated enforcement powers through regulatory boards like the SBN. The purpose is far grander: to protect public health, safety, and welfare by establishing professional standards and minimal competency that have to be enforced by law.
So it's the legal right granted by the state, usually after an exam, to actually practice the profession.
Precisely.
This brings us to the crucial difference between permissive and mandatory licensure models. Let's start with the historical model, permissive licensure.
Okay. Permissive licensure only protected the title, the words registered nurse, allowed anyone to perform nursing functions as long as they didn't use the letters RN after their name.
So if someone didn't use the title, they could still function as a nurse without any education or legal oversight. I mean, that completely undermines the point of safety standards.
Exactly. And this model had its defenders. Healthcare administrators at the time often appealed to the cost-saving aspect, arguing it allowed them to employ less educated, lower-paid staff instead of higher-paid RNs.
But the care quality must have suffered.
Significantly. Even those administrators eventually recognized that the quality of care suffered when the education level of the provider was lower. So professional nursing organizations fought relentlessly against this, recognizing it as a direct threat to public safety and professional credibility.
Which is why mandatory licensure is now the current standard across all states today.
Correct. Mandatory licensure requires every individual who wishes to practice nursing, regardless of their specific title, LPN, LVN, RN, or APRN, to pass the appropriate licensure examination and register with the State Board of Nursing.
And the system requires different exams for different levels.
It does, ensuring that a baseline of minimal competency is met for every single licensed practitioner.
Now, the move to mandatory licensure forced SBNs to clearly delineate the scope of practice for different licensed levels, but the source material notes a significant modern challenge: the blurring of those lines.
This is a major issue today. The blurring was initially exacerbated by the introduction of new educational pathways, like the associate degree in nursing. But the most problematic blurring today involves unlicensed personnel.
You're talking about certified nursing assistants, CNAs, and unlicensed assistive personnel, UAP.
Exactly. These individuals are supposed to be supervised by an RN or LP and LVN, performing delegated, non-nursing tasks.
Right.
But what we often see in practice, driven by cost containment and staffing shortages, is the unauthorized, often inappropriate, delegation of advanced nursing tasks to these unlicensed assistive personnel.
And the RN is still legally accountable.
The RN remains legally accountable, but the actual duty is being performed by someone without the training or the licensure.
So we effectively have an unofficial, problematic return to permissive licensure today.
That's precisely the danger. It's a widespread institutional use of unlicensed individuals performing duties above their level of training, which compromises the very professional standards that mandatory licensure was designed to protect. Nurses, especially RNs, have to be acutely aware of their legal accountability for the tasks they delegate.
Okay, now let's discuss an alternative regulatory concept that nursing organizations universally and vehemently reject: institutional licensure. What does this concept entail?
Institutional licensure would be a complete overhaul of the system. It would empower individual healthcare institutions, say a specific hospital or a clinic chain, to determine who is qualified to practice nursing within their walls.
So the state would just step back from setting the standard.
The state would step back.
Yeah,
And from a professional standpoint, that sounds like a disaster for accountability and quality.
it does.
It is universally rejected by every major nursing organization because of three critical immediate problems. First, there would be no external control to determine a minimal level of competency.
Meaning quality standards would just rise and fall with the institution's budget.
Right. The professional designations of RN and LPN LVN would become meaningless because the standard would be set by the institution itself, not the state.
And the mobility of the workforce would essentially just cease.
That's the second catastrophe.
Yeah.
If a nurse moved jobs, they would have to undergo a new institution-specific licensure procedure at every single new facility. This entirely eliminates reciprocity, or licensure by endorsement.
Which is the cornerstone of a mobile workforce.
It is. Reciprocity allows a nurse licensed in, say, State A, to easily obtain a license in State B, recognizing their existing qualifications. Institutional licensure would just destroy that ease of movement.
The sources also point out a backdoor approach where institutions try to skirt mandatory licensure.
This often happens when hospitals try to cut costs by employing foreign graduate nurses without requiring them to pass the U.S. licensure examination, the NCLEX. They calculate that the savings in lower wages offset potential quality decreases or the cost of training.
And state nursing organizations have mobilized against that.
Intensely. They've mobilized intense lobbying efforts to defeat any legislation that supports this, viewing it as a thinly veiled attempt to implement institutional licensure covertly.
That brings us neatly to the next level of professional identity. We've established the minimal legal standard with mandatory licensure. Now let's talk about the advanced achievement standard: professional certification and advanced practice roles in Section 3.
This transition is so crucial because we have to clearly differentiate certification from licensure. As we've noted, even nurses sometimes confuse the two concepts.
Okay, let's define them again clearly. Licensure is the legal requirement established by the state. It sets the minimal level of competency necessary for safe practice and public protection.
Right. In contrast, certification is typically voluntary. It's the granting of credentials to an individual who has achieved a level of ability that is higher than the minimal level required for licensure.
So it indicates expertise in a defined specialty area of practice.
Exactly. Licensure is your floor. Certification is your ceiling.
The source material notes that the public, employers, and even nurses themselves struggle with the precise meaning of certification. Why is there so much confusion?
It's largely due to the sheer variety of bodies that offer it. Unlike licensure, which is standardized by the SBN, certification can be offered by a large number of professional specialty groups, like the American Association of Critical Care Nurses.
Not the college's one.
Right, not the AACN we talked about before, or it can be offered by national umbrella organizations like the National League for Nursing, NLN, or the American Nurses Association, ANA. The proliferation of certifying bodies in specific focus areas just adds layers of complexity.
Let's look at the most common type: individual certification.
Individual certification is when a nurse demonstrates advanced attainment of skill in a focused area. The process usually involves several components: passing a rigorous written or practical examination, maintaining skills through mandatory continuing education units, or CEUs, specific to that specialty, and undergoing periodic recertification, which often requires repeating the exam or demonstrating extensive practice hours and continued CEUs.
And the ANA's certifying organization is the American Nurses Credentialing Center, the ANCC. They offer certifications in over 40 distinct areas, right?
That's right. Now, moving from the individual professional to the institution, we discuss organizational certification, which we typically just call accreditation.
Okay.
This is the certification of an entire group, program, or healthcare institution by an external, often non-governmental agency. The Joint Commission, or TJC, accreditation for hospitals, is a classic example.
Why is this organizational certification so vital to the modern healthcare system?
Oh, it is absolutely critical for the business and financial viability of the institution. A hospital's ability to collect money from federal programs, especially the Centers for Medicare and Medicaid Services, CMS, is often contingent on maintaining TJC or similar accreditation.
And it affects employment, too.
Hugely. For a nurse to work in a federal facility, the military, the VA, Indian Health Services, they must have graduated from a nursing program accredited by either ACN or CCNE, which are the main organizational certifying bodies for education.
This brings us to Advanced Practice Registered Nurses, APRNs. Here, certification isn't always voluntary, is it? It often becomes a legal requirement.
Yes, this is the regulatory overlap. For APRNs, state governments recognizing the complexity and risk involved, they step in. They may award or legally recognize certification, making it a legal requirement for practice at that advanced level.
And the state's Nurse Practice Act then dictates the specific activities a certified APRN can legally carry out.
Exactly.
Can you give us the specific example of the nurse midwife, CNM? How does the MPA delineate their scope?
The certified nurse midwife is a perfect illustration. In a state that legally recognizes the CNM role, the certified nurse midwife is allowed to perform a defined scope of activities, such as prenatal exams, teaching, and managing vaginal deliveries in uncomplicated pregnancies.
Okay.
However, based on that specific state's NPA, they are generally not permitted to perform surgical procedures like C-sections. The certification proves competency. The NPA draws the legally enforceable line for practice.
Historically, though, this has led to a regulatory nightmare because standards just varied wildly.
They did. For years, legal recognition, practice guidelines, and educational standards for APRNs were all inconsistent, not just across different states, but even between certifying organizations in the same specialty.
That sounds like a mess.
It created what we can only call a regulatory swamp, making it difficult for APRNs to move or practice across state lines and causing confusion among patients and employers. Healthcare reform, particularly in light of workforce needs, demanded standardization.
And that imperative leads us seamlessly into Section 4. The unified solution, the APRN consensus model.
The regulatory inconsistency we just discussed really reached a breaking point with the passage of the Affordable Care Act, ACA, in 2010. The ACA explicitly recognized APRNs as extremely valuable assets, particularly for expanding access to primary care. The goal was to leverage the APRN skill set to manage the projected influx of newly insured clients.
And the American Nurses Association, ANA, quickly capitalized on this recognition.
They did. In 2013, the ANA recommended that the Centers for Medicare and Medicaid Services, CMS, require state health insurance exchanges to include a substantial minimum number of APRNs in their networks.
What was the benchmark?
The suggested benchmark was equal to 10% of the APRNs independently billing Medicare Part B in that state, a recommendation that underscores the massive role APRNs were already playing.
But this growing recognition and scope have really intensified the political friction, right? Creating this constant rivalry between nursing and medicine at the legislative level.
It had.
What is the fundamental issue here, often disguised by debates over educational standards?
The fundamental issue is control. The American Medical Association, the AMA, has historically viewed EPRNs moving toward full practice authority as a direct threat to their traditional scope of practice and, their economic livelihood.
So while they publicly focus research funds on comparing the educational prep of APRNs versus MDs,
arguing a deficit in training, the core battle is about who has the legal right to control the boundaries of the nursing profession.
so the argument isn't really about patient safety, it's about professional territory.
It boils down to turf protection. Nursing, as a distinct profession, must establish its own regulations to define and achieve its professional outcomes. Allowing other groups, especially medical groups, to dictate the boundaries is surrendering professional autonomy.
So what's the takeaway for nurses?
The actionable takeaway for every nurse is clear. You have to be politically engaged, monitor all legislation that attempts to change the nursing scope, and stand firm to guard against regulation imposed by external forces.
To fix the historical inconsistency affecting the nearly 300,000 APRNs, the nursing profession developed the definitive solution, the APRN consensus model.
Yes, the model was the product of a unified effort by the APRN Consensus Workgroup and the NCSBN APRN Advisory Committee. They issued a major report in 2008.
And their goal was huge.
Monumental. To implement a unified model across all states by 2015, solving the problems of inconsistent legal regulation, title variation, scope of practice differences, and varying education requirements. And by the early 2010s, many states were well underway with implementation.
This standardization effort is often summarized by its 4 pillars: The acronym LSAE.
Right. LCA stands for Licensure, Accreditation, Certification, and Education. And LC isn't the model itself, but is the operational blueprint, the framework used to debate, implement, and execute the consensus model. It forces state boards and professional bodies to look at all four regulatory components simultaneously to ensure alignment.
Let's look at the definitive blueprint. The National Council of State Boards of Nursing, NCSBN, establish a uniform definition. What are the 7 key elements that define the APRN role across the country?
This is crucial for every APRN to know. First, education. They must complete an accredited graduate-level education program that prepares them for one of the 4 recognized APRN roles.
Okay, that's number 1.
Second, certification. They have to pass a national certification exam that measures both role and population competencies, and they had to maintain that competence through mandatory recertification.
3.
Advanced clinical focus. Their practice must focus on advanced clinical knowledge and skills for direct care. This distinguishes them from purely administrative or academic nurses.
Okay, 4 is autonomy and depth.
Yes, their practice builds on RN competencies, but with greater depth, synthesis of information, complexity of skills, and significantly greater role autonomy.
And 5 is responsibility.
They are educationally prepared to assume full responsibility for health promotion, comprehensive assessment, diagnosis, and management, and this absolutely includes prescribing pharmacologic and non-pharmacologic interventions.
So number 6 is experience.
They must have sufficient clinical experience to adequately reflect the type of license they are seeking.
And finally, number 7.
Role licensing. They have to be licensed to practice in one of the 4 recognized roles. Certified Registered Nurse Anesthetist, CRNA, Certified Nurse Midwife, CNM, Clinical Nurse Specialist, CNS, or Certified Nurse Practitioner, CNP.
That uniform definition finally eliminates the title confusion that plagued the profession. How does the consensus model mandate professional title representation?
The model requires clarity. Advanced practice nurses must represent themselves with the umbrella title APRN, immediately followed by the specific role. For instance, APRN, CNP.
And if their practice is specialized?
That may follow, like APRN, CNP, pediatrics. If they are licensed in multiple roles, they must list them all. This ensures employers and the public know exactly what the nurse is qualified to do.
Now, a probing question about standardization. The goal is uniformity. But how does the consensus model handle nurses who have been practicing for decades under the older, varied standards?
That's where the crucial political tool of grandfathering comes in. If the consensus model didn't include grandfathering provisions, it would have faced intense opposition from thousands of established qualified nurses.
So it was a political necessity.
It was. Grandfathering allows currently practicing APRNs to continue the same level of practice as long as they maintain an active license, even if their original education didn't strictly meet the new unified standards.
But doesn't grandfathering inherently contradict the goal of standardization if you're allowing a segment of the workforce to bypass the new, supposedly superior educational requirements?
It is a necessary compromise to achieve the overarching goal of political adoption and workforce stability. The primary aim is to ensure future generations of APRNs meet a consistent high standard while not penalizing established professionals or disrupting the immediate healthcare supply.
But individual APRNs have to stay vigilant.
They must. They have to actively monitor their state's legislative updates to ensure those grandfathering provisions are robustly included. If they move states, they need that protection.
Turning to education, the model insists on program quality and consistency.
Absolutely. Educational programs must be pre-approved by recognized accrediting entities before students are allowed to enter. This ensures that graduates meet the explicit prerequisites for licensure and certification.
And while a master's degree is defined as the basic requirement under the consensus model,
The undeniable trend in nursing education is pushing rapidly toward the Doctor of Nursing Practice, DNP, as the terminal practice-focused degree for advanced practice.
what if a nurse wants to specialize in an area not explicitly listed in the 4 population focus areas, like, say, gerontology or palliative care?
Specialization, like oncology nursing or psychiatric care, is governed by professional organizations, not by the state boards of nursing.
So how does a nurse pursue that?
In 2 ways. They complete a pre-approved, population-focused APRN program first, becoming licensed and certified, and then pursue additional specialty education. Or they attend a highly specialized program that prepares them for both the population focus and the specialty concurrently.
But they still have to pass both exams.
They must still pass both the APRN certification and licensure exam and the specialty certification exam.
Before we leave this section, what is the ultimate warning the sources give to nurses about the ongoing implementation of the consensus model?
The warning is critical. The regulatory environment is not static. Nurses must constantly monitor proposed legislation because changes will always take place at the SBN level first.
And they need to be vigilant for what our sources call covert ways to undermine the profession.
Exactly. Covert ways that politicians, medical associations, or healthcare institutions try to reintroduce the concept of permissive or institutional licensure, which would immediately reduce nursing control over its own standards and practice.
That constant vigilance requires organized political action, which brings us to our final section, the indispensable power of professional nursing organizations.
The very establishment of a professional organization is a defining characteristic of a profession. If nursing wants to be recognized as autonomous and self-regulating, it has to have organizations that consolidate its power.
This is the strength in numbers principle, just amplified politically. Individually, a nurse's influence might be negligible, but that power is increased exponentially by the organization.
Right.
This allows nurses to negotiate for independence, supervise unlicensed personnel effectively, and most importantly, influence major policy decisions at the state and national levels. It's the channel that allows nursing to speak with one unified voice.
National nursing organizations are powerful precisely because they claim to represent the entire profession. They need large, unified memberships to back up that claim, which gives them immense political capital when they're addressing legislators, negotiating with physician groups, and advocating to the public.
Let's dive into the major national organizations, starting with the educational focus. We have the National League for Nursing, NLN.
The NLN's overriding purpose is to maintain and improve the standards of nursing education across all settings: hospital-based programs, industrial, and public health.
And their membership is mostly schools.
While individual nurses can join, its primary membership base comes from agency memberships, which are overwhelmingly schools of nursing themselves.
Their major function is accreditation through the Accreditation Commission for Education in Nursing, ACM.
Yes, ACN credits schools of nursing at all levels. When a school receives ACN accreditation, it signifies that the program meets rigorous national standards. This accreditation also allows nurses graduating from that program to be employed by federal facilities. They also provide testing, career info, and compile stats on nursing education.
Now, let's compare that to the American Association of Colleges of Nursing, ACN. It sounds like their focus overlaps with the NLN.
There is overlap, but the AACN focuses specifically on improving standards for higher education for professional nursing. Think of the NLN as accrediting nursing education broadly, while the ACN focuses specifically on the university track. They are responsible for developing the standards for baccalaureate education that form the theoretical basis for countless university curricula.
And their accreditation body is the Commission on Collegiate Nursing Education, CCNE.
Correct. The CCNE accredits baccalaureate and master's level programs, and yes, they are often seen as competing with ACN, but both serve the vital function of ensuring high educational standards. Membership in the AACN is limited strictly to deans and directors of programs offering baccalaureate or higher degrees, making it an organization focused on academic leadership.
Next, the powerhouse of the profession, the American Nurses Association, ANA.
The ANA evolved from those early concerns about practice quality. Its major purposes are threefold: improving health standards and access to care for the public, maintaining high standards for nursing practice, and finally, promoting the professional growth of nurses, which encompasses focusing on economic issues, working conditions, and professional independence.
The ANA underwent a significant structural reorganization recently to keep pace with rapid healthcare changes.
It did, specifically in 2012 and 2013. They streamlined their governance structure, reducing the board of directors and transitioning away from the traditional House of Delegates model toward a membership assembly.
Why the change?
It was done explicitly to increase responsiveness. They now create specialized committees to address specific high-priority issues like updating the official code of ethics for nurses, and then they disband those committees once the work is done.
The ANA's membership is primarily through 52 constituent organizations, the 50 states plus D.C. and Puerto Rico, but the source material highlights a crucial political weakness: low membership.
This is a major concern. Despite its immense power and its affordable dues, around $200 per year, which is relatively low given modern nursing salaries, the majority of nurses do not belong to the ANA.
And that hurts them politically.
It dramatically dilutes the organization's ability to claim it speaks for the entire nursing profession. When politicians see low membership numbers, they can sometimes dismiss the organization's claims of representing the nursing community.
Yet, despite that, the ANA remains critical because of its role in setting standards.
They are the legal yardstick. The ANA established the official code of ethics that guides all professional practice, and they continually update the standards of nursing practice, which are the legal benchmark against which nurses are measured and held accountable in courts of law.
And they've been pushing for the BSN as entry level for decades.
Since 1958, they've been the driving force behind the policy of supporting the baccalaureate degree as the minimum educational requirement for professional practice.
And politically, they wield substantial influence in Washington, D.C.
The ANA Political Action Committee, ANA PAC, is one of the most powerful healthcare lobbies in Washington. This PAC is the financial muscle that prevents restrictive medical lobbying from kneecapping the nursing scope of practice. It influences legislation on nurses, nursing, and healthcare reform generally.
The appear and consensus model really relies on them.
Heavily. Its success relies on the strength of the ANA PAC and its ability to mobilize political action.
Let's briefly touch upon the National Student Nurses Association, NSNA.
Established in 1953, the NSNA provides a critical entry point for professional identity. Its purpose is to represent the needs and concerns of nursing students, helping them maintain high standards of education and professional behavior.
What are the key benefits of joining early?
Well, students pay low dues and receive tangible benefits like scholarships and publications. But most importantly, the NSNA provides political representation on issues that affect their education. By participating in NSNA activities like community health screening programs, students internalize professional attitudes, which they carry forward.
It's about fostering that identity from day one.
Exactly.
Moving globally, we have the International Council of Nurses, ICN.
The ICN is the massive international organization, with the ANA being one of over 100 member nursing associations worldwide. They meet every 4 years, and their goal is expansive: improving health and nursing care globally, coordinating efforts with the United Nations, and focusing on the social and economic welfare of nurses internationally.
And finally, the Honors Organization, Sigma Theta Tau.
This is an international honors organization established in colleges and universities to recognize leadership and significant contributions to professional nursing. Their activities are centered on scholarly pursuits. They promote nursing research, maintain a large library for members, distribute funds for research, and famously publish the first online nursing journal.
Now let's look at where the conflict and energy often originate. Grassroots organizations.
All nursing organizations start as grassroots efforts, right? Local groups trying to solve a specific problem. But the sources note that large national organizations, despite their political power, can sometimes become detached from fundamental local issues, like inadequate staffing ratios or downskilling.
What's downskilling again?
That's the dangerous trend of replacing licensed RNs with cheaper, unlicensed technicians.
So how do grassroots groups differ in their approach?
They use intensive, localized tactics because their members are passionately concerned about one or two issues that affect them directly, like mandated patient ratios. They can bring concentrated, rapid response power to bear on local legislators.
And they use more aggressive tactics.
They often do. Tactics frowned upon by the established nationals, such as actively seeking critical media attention, marching, and testifying fiercely before committee hearings.
We have two key examples of this tension in the source material.
First, the California Nurses Association, CNA, famously broke away from the ANA. Their frustration stemmed from the feeling that the national organization wasn't adequately addressing key state issues like hospital stay length reductions, inadequate professional staffing, and the preoccupation of hospital management with profit over patient safety.
They wanted a more localized political engine?
They decided they needed one. Second, the Nurses of Pennsylvania, NPA, formed a completely new organization focused almost exclusively on combating the issue of downskilling that pushed to replace licensed nurses with UAPs.
Beyond these specific breakaways and local groups, we also see the growth of special interest organizations.
Yes, organized by clinical practice, like flight nursing, or by education, or common ethnic and cultural backgrounds, like the National Black Nurses Association.
These specialty groups are essential for setting specific standards in complex areas, but the sources caution that this proliferation carries a risk: fragmentation.
This is the ultimate danger to nursing power. While specialization is necessary given the complexity of modern medicine, the proliferation of specialty groups, especially those that choose not to align their political messaging with the ANA, can dilute the unity and political strength of nursing as a whole.
How does that play out?
If legislators receive conflicting views from a dozen different nursing groups on a major policy issue, they may easily become confused, or worse, simply disregard the professional opinion entirely.
So unity on major macro policy issues like scope of practice and mandatory licensure is absolutely essential if nursing is to maintain political influence over its future.
The challenge for contemporary nursing, therefore, is leveraging the necessary diversity and specialization of the profession as a positive force, while finding common ground and uniting on critical policy issues to maintain control over the profession's scope.
That makes the history, the regulations, and the organizations far more than just bureaucratic details. They are the tools for professional autonomy.
Let's consolidate the core professional takeaways from this expansive deep dive. Remember the dichotomy. Licensure, granted by the state, establishes the mandatory minimal level of competency and safety required to practice. It's the floor.
And certification, often voluntary, demonstrates a higher specialized level of ability. It's the ceiling of expertise.
Both are essential credentials that prevent the profession from lapsing into chaos and securing that critical public trust.
And the importance of professional organizations cannot be overstated. They were the engines that created the standards, initiated mandatory licensure, and drove the push for advanced practice uniformity through LAE.
They serve as the indispensable channel of communication and political power that allows nurses to proactively shape health policy rather than simply being forced to react to policies dictated by others. The current challenge remains maintaining unity, leveraging that diversity constructively, and ensuring that nursing, as a unified political body, maintains absolute control over its professional scope and its future role in the evolving healthcare system.
To leave you with a final thought that ties these concepts of regulation and professional power directly to ethical practice, let's revisit a type of conflict every nurse will face. This scenario perfectly illustrates the tension between institutional survival and upholding fundamental professional standards.
Okay, imagine the case of Juanita R., a dedicated RN volunteering at a struggling storefront clinic that serves a highly vulnerable, indigent population. Her small, local grassroots organization, the Storefront Clinic Nurses, is offered a substantial financial grant from a pharmaceutical company.
But there's a condition.
There is. The condition is that the nurses collect data on a new antihypertensive drug specifically, recording blood pressures and reported side effects from the clinic's clientele. The company insists that because the drug is already FDA approved, no complicated research consent forms are needed.
But Juanita feels deeply uncomfortable using the clinic's vulnerable clients for data collection without full, formal, and understood consent, even though this grant is the only way to keep the clinic's doors open and continue serving the community.
The dilemma is acute. It pits the immediate need for financial stability, the survival of the institution, against the foundational ethical obligation of prioritizing the protection of vulnerable clients. This challenge highlights why the ANA established the Code of Ethics and why the profession must have external standards of conduct.
So here's the question for you to mull over. When institutional survival conflicts with professional standards, when the financial need threatens ethical practice, how do professional organizations and individual nurses use their collective power or their individual moral authority to navigate such ethical crossroads and ensure that the protection of the client remains the highest priority?
Thank you for joining us for this crucial deep dive into the regulatory framework that provides the structure and the power necessary for professional nursing.
We hope you walk away feeling not just well-informed about the acronyms, but truly empowered to engage with these powerful structures, knowing that your role is defined by standards fought for by generations of nurses. We'll see you next time on The Deep Dive.